Hello, I'm Johannes Mann, and I have the pleasure to moderate this session where we will listen to a presentation of Dr. Alfred Cheung. First, thanks to all of you from around the world joining this webinar, which is coordinated by Piero Segantini from the ISN headquarters. I am Johannes Mann from the University of Erlangen and also head of a kidney center, non-profit kidney center in Munich, Germany. The presentation will be on the blood pressure management in patients with chronic kidney disease and the results of a two-year work of a lot of people, which was summarized by Alfred Cheung, who is, as myself, a professor of medicine at the University of Utah, where he also directs the Department of Nephrology and Hypertension. And I must say that Alfred, as myself, is involved in a lot of outcome studies in patients with chronic kidney disease. And he is, so to say, one of the masterminds of the SPRINT study, and particularly of the SPRINT CKD study, as well as his SPRINT study in seniors. He will talk about that. While Dr. Cheung is talking, you may, and I hope you will, have a lot of questions. When you look at your control panel, there's an icon for questions, and that's where you can type in your questions along the talk. We'll probably not interrupt Alfred while he is talking, but we will have a long time after the talk for discussing your questions. And I'm sure for this topic, which is in a number of places quite controversial, we will discuss a lot. That being said, Alfred, I'm very much looking forward to your talk because we were collaborating a lot during the last 2 years as co-chairs of a guideline panel on the topic. Alfred, you're up.
Thank you very much, Hans. I welcome everybody from all over the world in this particular difficult COVID era. My assignment here is to talk about the blood pressure guideline from KDIGO, a update from the 2012 guideline. And I'd like to emphasize, as you can see in the red, this is only for non-dialysis patients. And for my disclosure, I have a consultancy with Boehringer Ingelheim, but not related to blood pressure or blood pressure medicine. But I was an investigator of the SPRINT grant, which I will also talk about too during the discussion. Here's the work group. It is wide in scope and involve people from several continents and had the prior experiences in CKD and hypertension. We have some prior blood pressure guideline work group members, but also some new members. And we have a very strong evidence review team from Cochrane. So the outline of the talk is what is new since the 2012 blood pressure guideline. And I could not believe that how fast time has gone. It's already 8 years. We will briefly talk about the rigorous guideline development process and the grading of recommendation, assessment, development, and evaluation methodology that we follow, and a new feature of the KDIGO guideline. And I will actually read off the guideline statements, 5 chapters: blood pressure measurement, lifestyle treatment for lowering blood pressure in CKD non-dialysis patients, blood pressure management in CKD non-dialysis patients with and without diabetes, which are combined now in the current guideline, blood pressure management in kidney transplant recipient, and finally, blood pressure management in children with CKD. And the 2 bolded chapters, blood pressure measurement and also blood pressure management in CKD non-dialysis patients are somewhat, they are quite new. So I will spend more time and talk about the rationale. The chapter 3 is highlighted in red because unlike the other chapters, which has received about 90 to 100% approval rating from the public commentary, the chapter 3 of blood pressure management is only a little bit over 60%. So it's controversial, and that's why I would like to spend more time. And finally, hopefully we have a lot of time for questions and answering. So what is new since 2012 that deserves an update? Well, there has been more work and emphasis on the technique of blood pressure measurement, which was really not emphasized at all in the last original guideline. And there is the SPRINT trial and sub-study of the SPRINT trial, the SPRINT CKD, and the SPRINT Mind, which we'll talk a little bit more about. And there has been joint analysis of SPRINT and ACCORD. ACCORD is the blood pressure trial and glucose trial in diabetic patients. And there are more subgroup analysis of ACCORD done. And finally, there are large meta-analysis on blood pressure in CKD and non-CKD populations. So the evidence review is done by Cochrane, and they already have a great database kept up with kidney issues. And they're old PICO questions, which I'll go into the next slide, but also new PICO questions. And we have identified critical and important outcomes instead of any outcomes. We define those outcomes prior to the literature search, and we focus primarily on randomized clinical trials. So a priori, we define the critical outcomes to be all-cause mortality, ESRD, cardiovascular outcomes, dementia and cognitive function, which most people believe are very important. In addition, there are outcomes such as doubling of serum creatinine, acute kidney injury, falling down, which people worry about with low blood pressure, and also fatigue. So these outcomes were predefined. So let's now very quickly go through the PICO questions. In populations, I would not read all of these, but to highlight the on red, we have the CKD population and we have general population. We look at children, elderly, and transplant. For the intervention, we look at blood pressure measurement, blood pressure target, and blood pressure medications. And then we have different comparators. And finally, the outcome, we want to look at the critical and important outcomes that I defined in the last slide. So I would not go through this chart here, but after a lot of work, concentrating on randomized trial, but supplemented by some systematic review and some observational study, we end up with 267 studies with 198 randomized trial and 56 systematic review of the general population. So this is the one new feature of KDIGO that we are incorporating. Previously, we have recommendations, but now in addition to recommendations, we have practice points. And the practice points are consensus statements based on our work group experiences and sometimes with limited evidence. And because there's limited evidence, they are not graded for either evidence or recommendation. And they are meant to be supplementary to the recommendation that we make. So in each of the chapters, you will see recommendations which are graded and practice points that are not graded. So the draft of the guidelines were sent out for public commentary for a little bit over 1 month, and it came back several weeks ago. And very strong, as I said, in very favorable in rating, except for the blood pressure target. All commentaries are carefully being considered, and the revision is still in progress. So first, blood pressure measurement, recommendation 1.1, we recommend standardized office blood pressure in preference to routine blood pressure for the diagnosis and management of high blood pressure in adults, graded as 1B. And the practice point is that oscillometric blood pressure device may be preferable to manual device for standardized office blood pressure measurement. I want to emphasize 2 points. We said that it may be preferable. It is a practice point, not a recommendation. And we are talking about here is that it is comparing oscillometric measurements with manual measurements, but it can both be standardized. Standardized doesn't mean that you have to use oscillometric device, which we'll talk more about. Point number 2 is that automated office blood pressure, AOBP, may be preferable for standardized office blood pressure measurement. Again, standardized office blood pressure measurement, whether you standardize or not, does not have anything to do with the type of machine that you use. So let's talk a little bit about standardized blood pressure measurement. Standardization really means that the key is proper preparation. When you ask the patient to abstain from substances that might elevate the blood pressure, proper positioning, keep them quiet, relax for 5 minutes. As you know, if you talk to the patient and irritate them and fight with them, that would increase the blood pressure, right? We want to use validated equipment, but not necessarily automated. And the cup size has to be correct and well positioned. So the advantage of standardized blood pressure is that these blood pressure measurements are employed in large randomized trials such as the CORD and SPRINT. It minimizes misclassification that leads to over-treatment and under-treatment of high blood pressure. The disadvantage that if you ask the patients to do certain things, keep them quiet for 5 minutes, it requires staff training and retraining, and requires more time of the patient, the providers, and the staff. Okay, but again, allow me to reemphasize, standardizations is really proper preparation and not necessary to do with the equipment. And allow me also to reemphasize that standardization eliminate a lot of variability. We want standardization in the measurement of serum creatinine in the lab. We want standardization in measurements of potassium, right? Avoid hemolyzed blood to measurement of hemoglobin or hematocrit. So we should also standardize blood pressure measurement. Second is the lifestyle for lowering blood pressure. We are not talking about lifestyle in general for decreasing incidence of cancer or cardiovascular disease in general. This is really talking about lifestyle in lowering blood pressure. Salt intake, number 1. Recommendation, we suggest targeting salt intake to less than 90 millimole or 2 grams per day of sodium, corresponding for about 5 grams of sodium chloride among CKD patients with high blood pressure. Evidence and the recommendation is 2C. Practice point, dietary sodium restriction is usually not appropriate for patients with sodium wasting nephropathy. We do not necessarily want all patients with CKD to have salt restriction. Point number, practice point is that the DASH diet so popular in the non-CKD patient or using salt substitute, which are rich in potassium, may not be appropriate in patients with advanced CKD or those patients with hyporenin, hypoaldol, because of potential for hyperkalemia. And finally, we cautioned the practitioners that there might be medication that is sodium containing. And then also in chapter 2 is lifestyle, physical activities in lowering blood pressure specifically. We suggest the patient with high blood pressure and CKD to undertake moderate intensity physical activities for a cumulative duration of at least 150 minutes per week. That means maybe about 20 minutes a day, or to a level that is compatible to their cardiovascular physical tolerance. We're talking about here moderate intensity. Okay. Practice point, we need to consider the cardiorespiratory fitness status, physical limitation, cognitive function, risk of falls when deciding the implementation and intensity of physical activities. The form of intensity of physical activity should be considered and modified as necessary for individual patients, and there may still be important health benefit, even if the physical activities falls below the target proposed the general population. Even standing at your desk is better than sitting in the chair all the time. Next, we'll talk about Chapter 3, the target, which is the most controversial chapter. We suggest that adults with CKD and high blood pressure be treated with a target systolic blood pressure of less than 120, using standardized office blood pressure measurement. It has to be standardized blood pressure measurement. The recommendation is weak because the potential benefits and harms may vary with a number of factors, such as CKD stage, we will talk more about, diabetes, we may talk more about. Individual with systolic blood pressure in the past has been called pre-hypertension, 120 to 129. Should you lower those to less than 120? It's less clear. People with very low diastolic blood pressure to start with, perhaps less than 50, okay? And particularly in those with coronary disease. I want to add that in this SPIN study, patients with diastolic blood pressure of 60 or above, they can benefit very well from further blood pressure lowering. The very old, I here give an example of 85 because the SPRINT showed that population about 80 up to 83, one standard deviation of 83 can still benefit. And frail patients can also benefit. But it's difficult for me to say what happened to the patient is very, very frail. That would be difficult. Right? So with the recommendation and some caveat, we make it a weak recommendation, but a lot of people are worried about the elderly, the frail, etc., and they said that these might be dangerous. And what I will be showing you is the evidence. It really is supportive of the broad categories, but emphasizing that individualization is the key in anything we practice medicine. We like have general guidelines, but you individualize based on your patient. So some have asked the question in the public commentary, should the guideline be broken into two parts? Some for the more general, especially CKD 3A, 3B, maybe 4, right? And but for the rest, it's a different recommendation. And this work group has debated very heavily about it. And our current stand is that we'll still combine all these groups, but recognizing the caveat, the recommendation is weaker for these subgroup. So we can discuss more about this later. So practice point of blood pressure target. It is potentially hazardous to apply the recommendation of systolic lower than 120 if you use non-standardized manner blood pressure. If you do not use standardized blood pressure, it could be hazardous. Point number 2 is that the clinician can reasonably offer less intensive blood pressure lowering in patients that you think have lower life expectancy, not necessarily because they're 80 years old, right? But if they have, of course, have advanced cancer or symptomatic hypotension, the patient not tolerate. Those you may want to have less intensive blood pressure lowering. Recommendations for the use of ACE inhibitor ARB We'll make it very brief because there's really not much new since the last blood pressure guideline. And we suggest the treatment of use ACE inhibitor ARB in people with CKD and high blood pressure. But the evidence varies between 1B and 2C, depending on the level of GFR and whether you have albuminuria. The evidence is strong to use ACE inhibitor ARB if you have heavy albuminuria. And the public commentary has asked us about diuretics and also other agents, and we are considering adding an algorithm to add on antihypertensive add-on on top of ACE inhibitor ARB, or maybe using diuretics as a first line as well for some patients. We're considering adding those algorithms. Now is, then we have practice points for RAS blockade, and ACE inhibitor ARB should be administered using the maximum recommended dose, recognizing that the maximum dose could be different from different countries with different regulatory agency. But in the studies using to prove the ACE inhibitor ARB to demonstrate benefits, they very often use the maximum recommended dose. Point number 2, mineralocorticoid antagonists, such as aldosterone antagonists, are effective in management of refractory hypertension as in the general population, but they may result in kidney function decline or hyperkalemia, especially in patients with low GFR. And there we ask that the newer potassium binders be considered, but there's not a whole lot of cumulative evidence yet. Chapter number 4 for transplant, we recommend that a dihydropyridine calcium channel blocker, such as amlodipine, or an ARB, be used as first-line blood pressure management as far as drug management is concerned for transplant recipient. Evidence, we call it a recommendation 1C. This is based on randomized trial, albeit rather limited. And practice point would be that the patient with kidney transplant recipient with a blood pressure target of less than 130, and diastolic less than 80. So this is somewhat different from the general CKD that we advocate, and we can talk more about that. But again, emphasizing you should use standardized blood pressure measurement. And final chapter is on children with CKD. And here we recommend that in children with CKD, blood pressure should be treated to lower the 24-hour mean arterial blood pressure, not systolic blood pressure, but mean arterial pressure, and also 24-hour as opposed to adult. We use office standardized blood pressure. So here we will be using 24-hour mean arterial blood pressure to less than or equal to 50 percentile of the age appropriate for age, sex, and height of the normal children nomogram. Right? Somewhat complex, but this is largely because of the ESCAPE trial, randomized trial published in New England Journal a number of years ago, where they use ambulatory blood pressure monitoring for 24 hours and target arterial blood pressure, and found evidence of decrease in GFR decline and ESRD. Okay, that's the basis for this recommendation. There's only one trial, and the evidence is 2C. Practice point, we suggest that monitoring blood pressure once a year with ABPM, but monitoring in addition with standardized office blood pressure every 3 to 6 months. Another point is to use ACE inhibitor ARB as first line for blood pressure management, primarily because of lowering of proteinuria and usually well tolerated, and not because of long-term cardiovascular mortality outcome. It is really only for we have evidence for lowering proteinuria. So now we have gone through all the guidelines. I'm going to spend some time to talk about blood pressure management and blood pressure measurement and also the blood pressure target, because these are newer guidelines and the target may be somewhat more controversial. So recommendation 1.1 is that we recommend standardized office blood pressure in preference to routine office blood pressure for diagnosis management of high blood pressure in adults. We give it pretty strong recommendation, 1B, right? And then furthermore, I'm just repeating it, oscillometric blood pressure device may be preferable to manual device, even for all standardized blood pressure measurements. And an automated device might be preferred over standardized device. So the automated, the advantage that it may increase the likelihood of adherence to proper blood pressure measurements, because the automated blood pressure will have resting in between, okay? And you can put the blood pressure cuff on and the staff might not be bothering you, right? So it would also remove potential sources of the person taking the blood pressure not being too careful, right? Manual blood pressure measurement. It may also reduce white coat hypertension, white coat effects, and free the staff. The staff, after putting the machine on, can also do other things. And importantly, automated blood pressure in the office are used in large randomized trial and large prospective cohort studies. And that's why we prefer automated office blood pressure. But what machine you use is really not as important as proper preparation, and that's what we meant by standardized, is proper preparation. So let's talk a little bit more about what is the difference in blood pressure measurement that you end up with between standardized office blood pressure versus routine office blood pressure. And here, Rajiv Agarwal published it about 3 years ago, and 275 CKD patients with eGFR mean of 29. What you see here is on the x-axis is the level of blood pressure by averaging the routine with the standardized. All right, you can just think of it as being the real blood pressure. And the y-axis will be telling us that what is the difference between standardized minus the routine. If routine blood pressure measurement is always 10 millimeters mercury higher than standardized, as some people advocate, you would not see all these dots all over the place. You would just see a flat line of the dots 10 millimeters mercury higher than standard. It would be flat. You would not be all over the place, because then the routine blood pressure will always be 10 millimeters mercury higher than standardized blood pressure. But what you see here is the dots is all over the place. You can the average is about 12 difference. Okay, meaning indeed that routine blood pressure is indeed higher than standardized blood pressure by 12.7, not more than 10 difference, right? Okay, instead of a straight line, you can see the dots are all over the place. So, but it can be as low as 46. The standardized blood pressure can be 46 lower than the routine. But distressingly, it can even be 20 higher, right? So what it tells you is that if you do not prepare the patient well for blood pressure measurement, and the patient is all angry and upset and have a lot of sympathetic discharge, you really do not know what the blood pressure you are taking. You do not know how to use it to guide the management. And that is the reason we really want to emphasize standardized office blood pressure, regardless of the type of instrument you use. So standardized blood pressure is generally lower than routine blood pressure, but cannot convert one to another in an individual patient just using a simple fudge factor. You cannot just add 10 or add minus 10, add 10. You cannot do that. Blood pressure measurement we suggest that these people like to use home blood pressure because they predict cardiovascular outcome well, and we fully acknowledge that to be the case. But nonetheless, we suggest that out-of-office blood pressure, just home blood pressure, be used as complementary to, and also out-of-office blood pressure and ambulatory blood pressure to use as complementary to standardized office blood pressure for the diagnosis and management. Okay, we are not saying that you should not do it. Okay, so the blood pressure status could differ between standardized office blood pressure and out-of-office blood pressure. If the standardized office blood pressure ends up to be higher to home blood pressure, that will be called white coat hypertension. Right? If they are lower, it will be masked hypertension. Okay, so we recognize that they could be different. This is a weak recommendation to use home blood pressure or ambulatory blood pressure to supplement, because the large clinical trials, such as SPRINT and the CORD, they are based on standardized office blood pressure and not based on home blood pressure. So even if home blood pressure predict cardiovascular outcomes, it's really difficult how to target it. So blood pressure target, we recommend that using standardized to be less than 120. So what are the caveats? This recommendation is weak because the benefit and harm can vary among some groups. For example, diabetes, which their CORD trial did not show an obvious benefit, will show that advanced CKD or heavy proteinuria, or the very old or the very frail. Right? And some people would say that, well, if you have less than 120 in the office, some patients might have white coat hypertension, and at home they may even be lower. Yes, that is indeed true. But 2 points I would like to make is that in the large randomized trials, such as SPRINT and the CORD, we also have white coat hypertension patients. We do not follow home blood pressure in those patients, right? And the second point is that you do have to use your own judgment. If the patient tells you that at home I am dizzy, right, and my home blood pressure is low, then you have to take that into consideration. But otherwise, we still advocate using standardized office blood pressure. So next, I want to talk about in the general population, is lower the better. And my summary on this slide is that indeed for many trials, 42 randomized trials, indeed lower is better, by seeing that this arrow here is slanted. It goes from, if you target less than 120, if you target 120 to 124, the benefit here is greater than if you target 150 to 154. Okay. So this is all I want you to get out of this slide here, is the lower the better in the general population, at least down to 120 to 124. And likewise, in the CKD population that Marocha and Joe X did this analysis, the meta-analysis, again, they show that in about 18 randomized trials, is that the lower is the better. Less than 125 is better than 125 to 135 is better than 135. And there, statistically, there is heterogeneity in the intensity. Okay. So both in general population, as shown in your last slide, and the CKD population, the lower is better. And specifically in the CORD and SPRINT, less than 120 seems to be beneficial. To some extent, I'll be showing you. So now let's turn to SPRINT, which has the largest randomized trial, where, in fact, the only large trial that shows examined blood pressure less than 120. And here we show that blood pressure less than 120 compared to less than 140 in the entire cohort, the cardiovascular outcome is better, and the CKD population is also the case, and there's no effect modification by baseline CKD. In other words, the lower the blood pressure, if you have CKD in the baseline, it does not change the effect of intensive blood pressure lowering. And it's the same for all-cause mortality. And there's also suggestion there is benefit to the brain. Okay. So some people have argued that, well, the CKD population, the confidence interval is not quite clinical significant. That's why you cannot trust the data. Right? So I will make the argument in this slide here, is that randomized trial, last trial, is only statistically powered to examine the whole cohort. We are lucky to see the effect in the old cohort. You cannot keep looking at subgroup and subgroup. For example, in SPRINT, we are happy to see the positive result in the entire SPRINT cohort. But if you start looking at females alone, it's not powered to look at female. In that female, it's statistically not quite significant. The sample size is too small. And if you said, I want to look at female Caucasian, of course, it's even less and less power, right? And some of the patients came from Boston. Okay, so now you ask the question, well, in people, the female Caucasian live in Boston, are they statistically significant? Of course not, right? So you cannot just keep looking at subgroup, and see if the result is positive or not. Very briefly, we worry about adverse events. There's hardly any statistical significance of adverse event in hypotension or CK or syncope or injurious falls, not statistically significant with lowering blood pressure in SPRINT. Even people over 75 years old, it is still significant in SPRINT senior, in cardiovascular outcome and all-cause mortality. And no difference in serious adverse event, orthostatic hypotension or injurious fall if you lower the blood pressure target less than 120. Very important for people who are worrying about the elderly cannot tolerate less than 120. Even in the subgroup greater than 80 years old, over 1,000 people in SPRINT, there's still cardiovascular and survival and cognitive function benefit, even over 80 years old. Specifically in CKD people over 75, still beneficial. In fact, numerically is even more so than those younger than 75. In cognitive function, there's a marginal improvement in probable dementia and statistically significant in this secondary outcome of the composite of probable dementia and mild cognitive impairment in the SPRINT population. So also benefit the brain. But again, individualization is the key, even though we want to have a general target. Right? So summarizing why this is for diabetic. In diabetic, I'll briefly tell you that there's no difference between the patients in the results in SPRINT and in their core trial targeting diabetic, but in the standard glycemic arm. No difference in the outcomes of intensive blood pressure lowering. No difference. Right? So the effect of intensive blood pressure lowering seems to be similar between diabetics and non-diabetic, but it's less certain is diabetic CKD similar to non-diabetic CKD as we see in the SPRINT. That's we are less certain. I will actually skip that one, but there's controversial data whether baseline eGFR really affects the effects of blood pressure lowering in CKD patients, but I can happy to address it later. How about intensive blood pressure lowering? Does it affect kidney function? It actually has slightly worse eGFR, but very small. Each year goes by, it's only half a mils per minute decline compared to 0.3. But albuminuria is less than in intense. Okay, so the eGFR is slightly worse, but albuminuria is better. And Larry Apple's the ASK study showing that the patient with proteinuria in the long run, in observational, after the randomization, in the long run, blood pressure lowering leads to better kidney outcome. Okay, so there's some suggestion that intensive blood pressure or lowering is also helpful in kidney outcome in proteinuria patients. So, summary about blood pressure lowering in less than 120. You must use standardized measurement. Routine blood pressure measurement is too erratic. Less than 120 seems to have favorable cardiovascular, brain, and survival benefits. Even for people over 75 years old, seems to and have favorable benefit-risk ratio. It's less certain in diabetics, CKD, eGFR very low, heavy proteinuria, the very old, I would say the over 83 or so, and very frail, okay? And the optimal blood pressure in this condition, however, is really not known. We don't know these people should be less than 130, less than 140. The evidence is not strong at all, even if you want to make this subgroup to be less than 130 or less than 140, okay? So general guidelines are useful instead of not knowing the data and then do any blood pressure target you want. It's good to know the evidence and have some general guidelines, and then you individualize. Right? So overall summary for my whole talk is that we emphasize standardized blood pressure measurements because they are used in large randomized trials. Blood pressure less than 120 is good, but emphasizing individualization and the caveats I talk about. Limited salt intake, intensive physical activity, not that much new. No significant change recommendation in RAS blockade, and with stronger evidence in heavy proteinuria. Blood pressure target in kidney transplant is still less than 130, over less than 180. Just because they have less data, there being no new data on transplant. And for children, it's still using ambulatory blood pressure to less than 50 percentile, appropriate for the age, sex, and height. And I thank you very much for your attention, and happy to entertain questions.
Alfred, thanks a lot. Thanks a lot for really a great talk, which summarizes elegantly a lot of work of the work group, and certainly some controversial areas that we went into. I want to take some of the questions. We are now to more than 200 attendees. And before I start with the first question that was posted, I'd like to emphasize that the guidelines are about patients with CKD, but not being on dialysis. And the first question asks about ABPM measurements, whether that type of measurement is the best to manage CKD patients with hypertension. What would be your answer, Alfred?
I think that my very brief answer is no for the time being, for the reason is that, yes, I fully acknowledge that home blood pressure and ABPM are very predictive of cardiovascular outcome. But whether you should target it is a very total different question. Predictive does not mean that targeting will be beneficial, right? So I think that until more data is available, we still advocate using standardized office blood pressure. And the ambulatory blood pressure measurement is helpful because it's still helpful as supplement because number one, it gives patients some sense of ownership. They're managing their blood pressure as some ownership, right? But also, if the blood pressure is really, really very drastically different at home, they should discuss it with the doctor, right? But not automatically change anything, right? But the large randomized trial is still targeted office blood pressure.
And there's also data that home blood pressure measurements increase compliance with treatment. So that may also be an advantage, doesn't it?
Right.
The ABPM actually, daytime mean ABPM correlates quite well with the AOBP. But nevertheless, there was none of the large outcome trials has ever taken ABPM as the typical measurement. It was always standardized blood pressure measurement, as you emphasize. The next question is, yeah, sorry.
I said I would love to have a randomized trial using ABPM. If somebody can sponsor, it will be a great study. Okay.
Yeah. All right. Yeah. Yeah. There should actually be more studies be sponsored, particularly in the CKD area. I mean, there's so many studies sponsored on different agents, but so few on the blood pressure targets. That's why the recommendation level is somewhat low. The next question is also of a practically important issue, namely, when do you ask the patient to take his antihypertensive medication in relation to the visit in your clinic, Alfred? Do you recommend anything about taking the timing of the antihypertensive drug intake?
Is it the timing of the day, or is that the question?
No. When they come to your clinic, do you tell them they should take their drugs in the morning, or do you tell them to not take their drugs on that day?
Oh, I ask them to take it according to the routine, what they do it at home. Okay, so I mean that's
what I also do.
Yeah.
Yeah, that's what I also do. And when the large outcome trials, when you look at those, patients also take the drugs regularly, and it does not depend on the visit at the clinic, yes or no. And the third, so far there are only 3 questions here. So if you have further questions, just ask, please. The next question is, how frequently do you recommend to measure serum potassium once you started anew with the treatment of ACE inhibitors or ARBs?
So if the patient has GFR, stage 3 GFR, and also does not tend to have high potassium, I think anywhere between 4 to 6 weeks is reasonable. Now, there are a lot of caveats there. CKD is not all the same, right? If you have low GFR, or if you have hyporenin hyperaldo, a lot of patients with diabetes, diabetic kidney disease, tubular insult disease, tubular interstitial disease, they are more prone to have hyperkalemia because they cannot secrete potassium in the tubule, right? Those patients, I sometimes check them in less than 2 weeks. Sometimes I even have them check in 1 week. I don't think I have them next day or something like that. That's outpatient. That's not really very practical. But if you have very low GFR or tendency to to high potassium, I would definitely check them within 2 weeks.
Is there a CKD level where you withdraw ACEs and ARBs? Was a question.
According to some experts, never. But I would say 2 reasons that I might withdraw it. Potassium is going to be a factor. And number 2, sometimes, not very often, I withdraw the ACE inhibitor and ARB just to see if there's any chance of returning kidney function. We know that giving ACE and ARB very often has an acute decline in GFR. Whether that is helpful or not is becoming more and more controversial, right? But nonetheless, there's an acute decline in GFR with ACE and ARB. Whether you withdraw it, does it go back up or not, is another factor. We see that in SGLT2 now, that acute drop, and withdrawing it after about 3 years, it might go back up, right? So I sometimes do not want to sacrifice that 15-20%. 15-20% in somebody with creatinine of 1 is not a huge deal if there is really long-term protection. You go serum creatinine go from 1 to 1.2. But for somebody who has a serum creatinine of 5 or 6, you lose 20%, the creatinine can jump up 1.1.5, right? And simultaneously, the potassium and the phosphorus can also go up. And I'm not ready to sacrifice that. So very often I do not add ACE inhibitor ARB in those circumstances. Whether I withdraw it or not, I do not do it often. But if I feel that the patient might have a chance of some recovery, or the patient is really resistant to renal replacement therapy, on rare occasion, I do some withdrawal, especially when the potassium is becoming more difficult to manage.
I can only echo your recommendation, and there is a randomized trial going on in the UK by the UK Kidney Association that is exactly testing whether withdrawal or not in a randomized fashion is producing results or not. And then there's another question, which is whether one can consider or not, when one wants to use a diuretic, thiazide or thiazide-like diuretics, with an eGFR below 30. I think it's not our favorite. I don't know how this is in Utah.
So a diuretic, I would say that if you like, try any diuretic with any GFR. In general, chlorthalidone seems, at least per unit dose per milligram, is stronger than hydrochlorothiazide, and is also used in large randomized trials. But is it really have separate beneficial effect in terms of outcome is unclear. In terms of effective in lowering blood pressure, chlorthalidone for milligram to milligram basis is more potent than hydrochlorothiazide, and some limited study show that it can be effective in lowering blood pressure with GFR down to perhaps around 20. Below 20, I think that that's really pushing it. And chlorthalidone was the preferred diuretic used in the SPRINT trial, and we indeed use many of those in stage 3B, stage 4 CKD.
And the next question was, why didn't we discuss diastolic blood pressure and only systolic blood pressure?
Yeah, so that is a topic that we thought about it quite a bit. And I think that's the reason the work group decided not to tread on diastolic blood pressure. There's several reasons. One of them, this literature in the last 10, 15 years is really concentrating on systolic blood pressure, because systolic blood pressure, especially in people over 50 years old, is much more predictive of cardiovascular outcome and more all-cause mortality than diastolic. That's number one. That's what SPRINT and what they're targeting systolic. Number two, by the time your systolic blood pressure is less than 120, which we're advocating, especially somebody with the little bit older, or even 65 years old, or CKD with some calcification, their diastolic is very unlikely to be very high at all, right? So a systolic of less than 120, very often you're going to have a diastolic less than 80. And we really do not have any randomized trial data of diastolic less than 80 in CKD patients. So that's why we decided not to target diastolic. But it will be reasonable to say that you also want the diastolic to be less than 80. But for the most part, we don't think it's necessary to specifically target it.
And we also discussed that the fear of more cardiovascular interventions, those with coronary artery disease at a low diastolic blood pressure, is more or less theoretical and not based on interventional trials.
May I just quickly elaborate? I want to answer as many questions as possible, but the diastolic blood pressure issue is very interesting. People talk about a J curve. There's indeed a J curve. We can see the J curve in SPRINT trial also if we use the SPRINT data, baseline data, as an observational study. In other words, if you plot on the x-axis the diastolic blood pressure at baseline versus clinical outcome, cardiovascular event, there was indeed a J curve.
the low people with very low diastolic blood pressure, they did not do well. But low diastolic blood pressure at baseline, if you still randomize them to lower their systolic blood pressure, which most of the time will end up with lower diastolic blood pressure as well, right? They still benefited from blood pressure lowering.
Exactly.
So those are two separate questions. Where diastolic blood pressure predicts bad outcome is different from whether you can still lower it or not. Those are two separate points that I really want to emphasize. So low diastolic blood pressure, at least to 60, does not concern us at all in further lowering the blood pressure.
Yeah. Alfred, a few fast questions for the last 4 minutes and fast answers. Do you make a difference when you use a calcium antagonist or calcium channel blocker, whether it's dihydropyridine or non-dihydropyridine? There are data on proteinuria differences, but do you make a difference in your patients?
I used to worry more about it, but now I become less and less. I think the evidence is really not very strong, not all that strong. And number two, the medication such as amlodipine actually has cardiovascular benefits. And so nowadays I take both the cardiovascular benefits and the kidney benefits all into consideration. And I am not making that much a distinction between them. But Hans, I like your opinion on this one as well.
I don't make a difference. My point is usually to reduce blood pressure, and then I use either one, usually dihydropyridines, because there are a lot of combination drugs also, so I only have to use one tablet with two drugs. And I use the non-dihydropyridines sometimes in patients when I want to reduce protein specifically, but that's rather a rare event. Then I have a question to you. Weren't you surprised when you looked at the side effects? We were talking about coronary artery disease, but falls. There were somewhat more falls in the sprint, more intensive blood pressure target, but there were not more fractures or injurious falls or whatsoever. Wasn't this a surprise?
Right. Well, I think that I'd like to just talk about sprint some more at the beginning of the trial. I really like the audience to hear this so that you understand that we are not being too over aggressive or cavalier about it all. We fully understand people's anxiety about treating people, the older people, with lowering blood pressure below 20. At the beginning of the trial, we debated, should we have two separate targets? The people 50 to 75 years old, should we have less than 120? And the people over 75 years old, should we be less than 130? Okay, but then after the high-vet trial results became available, we thought that you are not making that much of an advance if you also target blood pressure less than 130 in the people over 75, right? So we cautiously decided to study everybody, even those over 80 years old, 83 years old, with blood pressure less than 120, and watch them carefully. Lo and behold, there was no increase in syncope, in injurious fall as a whole group. Okay, as a whole group, that was not a problem. But I do not want to make it sound cavalier. Unless you really tried it, I really would prefer people to keep the piece of data in mind and make an attempt to lower the blood pressure gradually. I think if you start with blood pressure of systolic 160 and immediately get it down within a few weeks to less than 120, that you will have side effects and intolerability, even people who are younger. In these people, you just have to go sometimes several months to get it down lower and lower and lower. And if the patient, after you demonstrate that, they really cannot tolerate less than 120, then back off is perfectly fine, right? And may I say that even people 55 years old, if they cannot tolerate less than 120, you also back off. And somebody who is 80 years old, but if they tolerate less than 120, it's really no good reason to back off. So I think that the concern is very legitimate. I fully agree that concern. But the fear of not trying, I think, is not backed up by data. Okay. So that's the one strong point we like to make.
Now, you worked a lot today, so I had a more quiet time. Therefore, I will take the last question, which quite appropriately is about COVID-19. So I'm writing several chapters on that topic in UpToDate. I don't know whether worldwide UpToDate is used, but it may be. And the question is whether ACE inhibitors and ARBs should be taken off in hypertensive patients who are infected with COVID-19, so the SARS-CoV-2 virus. And the fast answer is no. The longer answer is a little bit more complicated. These drugs obviously increase the number of ACE2 enzymes sites, which are entry sites for the virus. But nevertheless, there are also very good arguments that for the virus itself, it's better that patients take ACE inhibitors and ARBs. And in addition to that, withdrawing suddenly effective drugs that lower blood pressure and potentially proteinuria and so forth in our CKD patients is dangerous. So you have to watch your patients very carefully, and therefore, based on no good arguments to withdraw it on the theoretical side, and second, the very obvious potential of harming your patients with a sudden withdrawal of those drugs speaks heavily against withdrawal at the present time of our knowledge. That would be my answer to that question. Is there a different view in the far west?
Well, I totally agree with you. The bottom line answer, and we have actually looked into it quite carefully, at least the literature, and it turns out that even in preclinical studies, the directionality of ACE inhibitor ARB is unclear. There's no question the ACE2 gene seems to promote viral entry into the lung cells, and but there's also data suggesting ACE inhibitor ARB might be helpful or harmful. We don't even not sure about the direction, and there is two randomized trial now trying to study that whether withdrawal ACE inhibitor ARB is good or bad in COVID patients. So without any further evidence, both in terms of evidence or in terms of theoretical basis, we do not really know.
Yeah, there were many questions to the same topic. I think we have answered most of the questions. Probably one for the nephrologists, Alfred and myself, to answer. How do we manage an increase in serum creatinine or decrease in GFR when we start to lower blood pressure? So a patient comes in with 170, we get it down in 2 weeks to 140 or so, and his creatinine goes from 2 to 2.4 or something like that. There is no good study that has actually answered that, I must say. There is also observational studies and looking at these patients in the long run. There are also differences in what was found. There's also a statistical point of regression to the mean. And it's actually a very individual question that is answered in different ways by different nephrologists. Now, having said that, my own management is that I first look at the the volume status of the patients. Frequently, the increase in serum creatinine or decrease in GFR is due to volume or too much diuretics. I can correct that easily and then go on. Sometimes it's a patient with renal artery stenosis. Then I have to watch that and look at it, what I want to do. And most of the time, when it's not volume, a volume problem, lack of intravascular volume, it's a patient with nephrosclerosis and arteries or arterioles that do not well adapt to a lower blood pressure level. And there, my point is to go slowly, but I tolerate increases in serum creatinine or a decrease in GFR in the range of 10, 20, 25%. Many textbooks say that you tolerate a decrease in 30%. Alfred, what's your management of those patients?
I don't have anything to add. It is, if we see that with lowering blood pressure, we see that with RAS blockade, we see that nowadays with SGLT2. You are hoping that this is really intratumoral dynamic. I cannot even tell you what is a very significant increase that would really bother me. But if you significant increase enough that you're seeing problem with potassium and phosphorus, that would bother me. Okay, that is the. But otherwise, if go up from 1 to 1.3, that would not really bother me. But I don't have any firm numbers to go by.
In addition to that, a good practice point here is that in most patients in whom it goes up, it will go down, probably not to zero to the beginning, but after a few weeks, it will go down. What's really bothering me, if you have somebody where it increases, but it's extremely rare, and that's usually due really to renal artery stenosis, when it goes up and up and up, then the patient really has a problem. But that's not the rule. The rule is it goes up and it comes down by at least 50% to what it came up. Okay. No further burning question came up. I thank the audience for staying with us, although we were a little bit over time. I thank Piero for organizing it from the ISN side, and a lot of applause. Alfred, I hope you hear it, but everybody was muted. Thanks a lot, Alfred.
Allow me to really thank the audience for all different hours to listen to us. I really thank you.
And in these times, have a nice weekend and please stay healthy. And with that, I will end and call off this.
Perfect. Thank you, Johannes. Thank you, Alfred, very much for your presentation and for your moderation. See you soon all around the world. Bye-bye.
Bye-bye.
Thank you. Bye-bye, everybody. Bye-bye, Alfred.